And I can just see that Becca's put in the chat as well. Thank you, Becca. If we could just ask that folk respect the fact that they don't press the settings or fiddle with any of the settings, as there was a few difficulties caused by members of the audience yesterday. So thank you for respecting that. Lovely. We can see some chat coming through, people introducing themselves. You are very welcome, and I'm just going to move forward now as you write in the chat who you are, where you work, and what you'd like to get out of this session. I've introduced myself and Caroline and Sarah already, so I was ahead of myself. So the agenda today is introducing NQICAN and Clinical Audit Awareness Week. If you have been to some of our events this week, and there have been some fantastic events, fantastic discussion, and I'm hoping we have the same today as we talk about health inequalities and really focusing on clinical audit and what does it mean from the clinical audit perspective. How do we use clinical audit effectively so we can influence change? We were talking yesterday, so reduce health inequalities through clinical audit. We have a presentation. Our key speaker, I beg your pardon, is Caroline today, and looking forward to hearing from Caroline about the work of HQIP related to health inequalities. And then we have presentation from the Health Inequalities Hero Award. And the winners we will then hear from as well. So Stop Press News, winners of the Health Inequalities Award. We are live in our session. Look forward to hearing from them shortly. We then have a networking opportunity, and Sarah Byrne is going to facilitate that discussion with myself and Vicky as well. And then we'll talk about the rest of Clinical Audit Awareness Week. And tomorrow is day 5. Tomorrow is the last day of this year's Clinical Audit Awareness Week. So just a little bit about NQICAN, so the National Quality Improvement and Clinical Audit Network. We run this network to look at what we're doing with clinical audit, and we do look at and we focus on how can we get high quality care for all? How can we put our patients and service users first? How can we make a difference, help patients get what they need most? And you know, it couldn't be any more relevant when we're talking about health inequalities. How can we influence that change through clinical audit? How do we provide health and well-being to our local communities and all those that are within it? So Clinical Audit Awareness Week is really important because we are looking at all those elements and trying to improve the quality of patient care, spotlighting on this week, yes, but actually recognising that this happens day in, day out, and this is about making sure that every interaction counts. Ultimately, we're trying to provide high quality and effective care to all in the right place at the right time, but also by trying to prevent harm and providing the best experience as well. And Tuesday's patient advocate, patient engagement lunch and learn really highlighted the importance about looking at experiences and understanding from the patient perspective as well. Clinical Audit Awareness Week, which we do proudly, NQICAN run proudly in collaboration with HQIP, the Healthcare Quality Improvement Partnership, are trying to use a platform. We're trying to improve the awareness of clinical audit so that we can share and celebrate what we are doing day in, day out, and actually making a difference. So the challenge, the request to yourselves is what you learn from your lunch and learns. Please just take time to reflect on what is working well, what we can celebrate and do celebrate, and actually what's not working as well, and how can we make that better? How can we improve that experience, that quality of care? And the challenge is set yourselves objectives, go back to your organisations. So tomorrow, look at what could you do differently in light of what you've heard today from the Lunch and Learn and any of the Lunch and Learns over the week, and try actually to take on that challenge and take that forward. Thank you. There's some great comments coming through and people introducing themselves. So thank you. Vicky and Sarah are looking at those, but it's great to see so many of you on this Lunch and Learn today. Just a tiny bit more about NQICAN. So we're made up of 12 regional chairs. Sarah Byrne is supporting us today from the Mersey Regional Chair. If you're not already a member, please do join us. Becca's going to put the our email address in the chat, and we can put you in touch with your regional chair, find out what they're doing. They're doing some excellent work out there. And through the Lunch and Learns this week, we've been supported by many of the different regional chairs, which really just brings to life the enormous amount of work that is out there. So really would encourage you to join your network, find out more, and do have a look at our website as well, which has got further supporting information. And Becca, if you can put the website address in there as well. So a lot of information from me. I'm just going to pause just for a second. Vicky, can I ask you to look at that comment in the chat, please, and work that through with Becca? Just going to pause with regards to a lot of information that I've given about NQI-CAM and about how we can actually use clinical audit to reduce health inequalities. It's now over to yourself, please. Can we ask you to go to Mentimeter? So Becca's about to put that in the chat just now, and we're just going to spend a few minutes thinking. I want each of you to think from your perspective. You're all in very different roles in different parts of the country. Think about what does utilising clinical audit to reduce health inequalities look like to you. So Becca, thank you. Becca's just put Mentimeter into the chat, and Becca, if you could take over the slides and put the Mentimeter up. We'll just give folk a few minutes. There's a code that will be up on the screen in just a second. So if you put that code into Mentimeter once you've got in, it will take you to this question.
See the Mentimeter, okay?
We are, thank you. So the code for everyone. Oh, brilliant! We've got points coming up. That's fantastic. So have a focus to understand health inequalities and outcomes in clinical audit. Lovely. Improved patient outcomes for all. Very important. People just typing in their responses. Improving outcomes for patients in high deprivation areas. Absolutely. To see standardised care for all. We're seeing for all coming through on a couple of points there. Working in partnership with people and communities to understand their relationship with services, to then understand, to audit and improve. Whoever wrote that in, fantastic. Absolutely love that statement. Identifying inequity, then holding teams, hospitals, ICSs to account. Right, whoever's put that comment in, what do we mean by hold to account? So most of us are working in clinical audit or the wider quality improvement. What do you mean by holding into account? So if we're working with clinicians, how can we hold to account? How could we take forward? And I'm actively encouraging the individual to please let's explore that. Pop in the chat how you think we could hold to account. And if not, we'll bring that back to the networking session. Sarah, if we can just make a note of that. Focusing on areas of inequalities on priority plans. Improvement for all, adapt and deliver appropriate services in a person-centered way. Absolutely. Adapt and deliver appropriate services in a person-centered way. Couldn't have said it better myself. I think the key with this is actually working in collaboration and being able to take forward, you know, in an appropriate patient-centered way. These slides will be shared, absolutely, and the video will be shared on the NQI-CAN YouTube channel as well, Phoebe. So you're more than welcome. When sharing services are of high standard. Oh, it's gone off the screen, but I'll catch up with it. Using audit to highlight where inequalities are, if not already known. So actually, we're finding out where the pockets of inequality are. Really good use of clinical audit and absolutely appropriate. to look at inequalities between stroke patients and other neurological conditions regarding, and it's just coming up, differences in commissioning and length of time for input. Yeah, really powerful statement there, absolutely. I'm just going to give just another minute. These are still coming through. Equity in accessing care in large geographical areas, absolutely. So if you're within a county, you're within an area, are there, towns, are there urban areas, are there more countryside areas? Do we have the same equity, the same accesses? Clinical audit to share best practice across all of the health economy to help all patients and staff delivering care to patients. Absolutely. Thank you. These are some really, really important points that are being raised. What does Bren mean? Did Bren put the comment in? Is that Bren's name?
Bren's our colleague from HCRIPS. Oh, there I can see you, Bren. Hi from the Service
Hi,
Network.
Bren. Thank you.
Hi, everybody. Yeah, so we often talk about commissioning, don't we, really? But we're sometimes a little bit shy and don't bring that word forward about decommissioning. So again, if we use those audits to find out actually we're increasing health inequalities with good intent, but we aren't actually doing that, then again, linking into the ICSs, etc., going forward, we've got to be brave enough, open, transparent enough to say, actually, we need to decommission that. That's my point on that one.
Bren, beautifully put, and it's a really important one, and one we can't shy away from. It's as important to commission pieces that is needed, as well as to decommission pieces that actually we've got that right level of care, and we need to focus on other areas. Thank you. Okay, Becca, let's come back to the slides then, please. Becca, do I need to live share again? Is that correct?
Yes.
Thank you. Bear with me 1 minute, just as I go back to the slides. And thank you ever so much, everyone, for participating. We will be able to download these comments, and what we're going to do is take forward and review the lunch and learn. We're asking you to fill in an evaluation form as well, where we're saying, what will you be taking back to your organisation? What are you going to take forward in light of what you've heard in the lunch and learn? So thank you. It's really powerful information. Carl Walker, you were telling me how to lock my slides. The I symbol at the top. Calling out to Carl, hopefully he's still there.
I am indeed, Sarah. You just need to press the I button if you don't want people to scroll through the presentation.
Thank you very much. I believe I've done that now, so thank you for that top tip. I'm not a Luddite, but to use PowerPoint Live is a little bit different than I'm used to. So thank you, everyone. Right, we are back. So we're just going to explore a little bit about health inequalities from the context really of defining and then looking at from clinical audit before I hand over to Caroline. Many of you will already recognise health inequalities, so apologies if this is a repeat for you, and bear with. We're obviously focusing on how we can reduce health inequalities as part of this lunch and learn. And clinical audit is an important tool to be able to look at, and the links, how we can look at best start in life, looking at ill health and prevention and healthy standards and living and healthy standards of living for all, I beg your pardon. Health inequalities ultimately are in the status of, health inequalities are ultimately about differences in the status of people's health, but the term is commonly used to refer to a difference in care people receive. So just need to think about, just perhaps pause and think about what that means to each of us, but our focus is on health inequalities, but you can see the links and the themes coming through. But what do we mean by inequalities, to whom? So you can see on the slides, it's about the differences in health statuses. It's about the things that determine if people in an experienced group have a range of factors. In England, health inequalities are often analysed with the points that we have here, and the range of factors are the socio-economic factors, for example, income, geography, so the region, be it urban or rural, specific characteristics, and those do include, and that's just a number of examples, sex, ethnicity or disability. The protected characteristics in full are age, disability, gender reassignment, marriage and civil partnership, pregnancy and maternity, race, religion or belief, sex and sexual orientation. We also need to think about the other factor in inequality is socially excluded groups, so people experiencing homelessness. There was a powerful piece with our local health watch that actually talked about a homeless gentleman that needed access to dental care, and you may have seen the advert or heard the advert on the radio that says no postcode, no care, no care, no postcode. You know, it just goes round and round in a loop. Really powerful, but actually we do need to think about how that is affecting our patients, our population. So I've got a couple of examples of references here. We've got a few as we come through. We will pop those in the chat just as we break for networking as well, so that those are available to you. So somebody's asking, should I be able to see the slides? You should be able to see the slide that is defining health inequalities. Can you see my notes though, Zoe? If you say yes or no, that would be appreciated.
Your slide, Sarah.
Just see the slide. Lovely. Yes, you should just be seeing the slide, Zoe. Thank you. So inequality also includes differences in health status, for example, life expectancies, the prevalence of health conditions, access to care, for example, availability to treatments. I've just talked about the accessibility of dental care, for example, with a homeless person. Behavioural risks to health, for example, smoking rates, and wider determinants of health, for example, quality of housing. If a house is very damp, how it will affect respiratory conditions, etc. And just again, just building on this in this definition of health inequalities in the background, we're just doing a light touch on these key points. There is a wealth of information out there, and really worth having a look at the references that I've given here, and we will put them in the chat. But why look at health inequalities? And it's really interesting. I have gone back to Marmot's review of 2010 on purpose. So you can see on bullet point number 2 that we've got a quote here from Marmot in reference number 1. Since 2010, life expectancy in England has stalled. I don't know if anyone's surprised by that, but actually I think it's a sad state of affairs. So the full quote in there is 2010 life expectancy in England has stalled. This has not happened since at least the 1900s, if that puts it into context. If health has stopped improving, it's a sign that society has stopped improving. When a society is flourishing, health tends to. So just pausing on that, it's a little bit humbling really when we look at that and thinking about the wider implications. And then that's been further impacted by the pandemic, so the COVID-19 pandemic, and as we continue to work through recovery. So there's been the illustration of the stark health inequalities and the differences in mortality, for example, between the different public groups. So that's the public health reference there for 2020. Marmot set out in 2010 6 priority areas. These won't be a surprise to you, but I do want to read them because I think it puts what we're talking about in context. So there's 6 priority areas covering the stages of life. Give every child the best start in life. Enable all children, young people and adults to maximise their capabilities and have control over their lives. Create fair employment and good work for all. Ensure a healthy standard of living for all. Create and develop healthy and sustainable places and communities. Strengthen the role and impact of ill health prevention. So that's moving to a proactive position where we're trying to avoid ill health. And actually, I think we're still very much on the reactive. Those threads, those 6 points, those 6 stages of lives, those priorities set in 2010, and we're still working on now. And just really quickly, just a holding point, you may recognise with the scissors the inequality picture taken from the NCPOD Health Inequalities Final Report published by HQIP, and I'll leave Caroline to comment on that. But I do just want to say by the other image that I have here, inequality hurts all of us. So it's within our gift for all of us to make a change in whatever role we're in, or whether we are speaking as a member of the public. So health inequalities are based on factors outside individuals' direct control. So people in England experience systematic, unfair and avoidable differences in their health, the care they receive and the opportunities that they have to lead healthy lives. And I'm quoting there from the King's Fund report, which again is really worth a read. Health inequalities are not inevitable, and we must remember that. And it's just the plea for almost the call to action to say we must make a change to this and each do our bit. So therefore, from the clinical audit perspective, effectively clinical auditing health inequalities, some considerations, just some things to think about. So I'm floating these at points now that we'll come back to in the networking session, so facilitated by Sarah. So there'll be opportunities to build on, opportunities to explore, ask questions. So does your clinical audit strategy have a clear objective to reduce inequalities? Do they clearly link with your organisation's wider strategies and as part of your ICS? We've seen in the chat the comments about working as a system, looking at pathways. We cannot be working in isolation. Do you include priority clinical audits in your clinical audit plan that focus on the local areas where there are health inequalities? And we saw again that coming through on that Mentimeter just now. So are these identified as part of your trust and your organisational priorities? So are we doing as per our ICSs? Are we taking forward the priorities? Is that very clearly in your clinical audit plan? Are we focusing on the priority projects we should be? Is the standard of care consistent across different groups? Again, that came through, do you get the same care in the urban area to the rural area? Do we have the same access to cancer care, considering access for younger people versus older people? So do we have ageism that can come in? So again, in the networking session, would love to hear about what you have established in your organisations. I also just want to bring in a patient engagement element. So we had our lunch and learn on Tuesday. If you couldn't join us, please do look at the YouTube video. It is live on our YouTube channel, and we can make the link available for you. But one of the points is about how do we engage people and how do we make sure that we're actually taking forward to ensure everyone gets the appropriate quality of care in the right way. Do we know through clinical audit, are we looking to see whether there are people from protected characteristics that don't have that same level of care as others? So have we focused clinical audit in that way? And actually, are we engaging with our patient groups within our local areas to allow patients the opportunity to have a voice, to say what matters to them, to be able to actually take forward and be able to support looking at the findings and support actions? So looking at a smart action plan and looking at how we can influence change as well. Also, how do we look at the information of health inequalities in your area? Are you linking in with your analysts, your business intelligence teams? In Dorset, we're very lucky to have the Dorset Intelligent and Insight Service, which we lovingly call DICE, and that feeds all information from all the NHS organisations and GPs, uploads overnight, and we have at the touch of a button information. So one project I'm working on at the moment is identifying within the Weymouth and Portland area, and this is public knowledge, so this is not anything I shouldn't be saying publicly, that there is an inequity in care within those areas and a higher level of deprivation, both with education, but also with cardiology, so looking at heart disease, and how can we get that information and that education out there? So do we know what tools we can use to actually support that moving forward? And as I said at Tuesday's Lunch and Learn, it's just about being mindful when we look at clinical audit. If we are pleased that we have 95% of patients have achieved a standard, if we're congratulating ourselves, what about the other 5%? One of our patient representatives actually said, what I expect is that 100% of patients get the quality of care that's expected. It is expected, and you can't argue with that, really. Mindful of time, I am handing over to Caroline. Caroline, would you like to take control of the slides, or would you like to just say next slide, please?
Oh, could I say next slide, please, rather than
Of course you can.
mess about with the technology? Thank you, and thanks, Sarah, for the good introduction. I am Caroline Rogers, and I'm at HQIP. I'm one of the associate directors. So I'm responsible for commissioning and contract managing a number of the projects in the NCAAW National Clinical Audit and Patient Outcomes Programme. So several national clinical audits and the National Child Mortality Database. But today I'm going to be talking about health inequalities across the whole programme, and HQIP's been doing some work on this over the last few months. I think we recognised that there's a bit to do on this subject, that we could do some more on this topic. NHS England have got a focus on this at the moment, so it seemed a good time to have a focus with our providers on this work. So I'm going to present some of that work that we've been doing to you today. So next slide, please. Thank you. So over the winter, spring, we held 4 workshops with our providers and with a few other helpful people as well, including Brent. I can see you there as a patient advocate. So I've got them up on the screen. We looked at a number of different topics. We brought our national clinical audit teams, so our providers based at their various organisations, together to really have a good chew through all the different subjects, and we held a wrap-up workshop with some external stakeholders and NHS England and NHS Digital and NICE and a few other people. And Vicky was very supportive on behalf of NQICAN, and we had a wrap-up workshop at the end of April. And we've got, and I'll present the findings now in a second. We've got a number of activities for ourselves to follow up on, and we've got a number of, let's call them challenges, for other organisations to follow up on, which we're picking up with them, and we made a number of recommendations. So if I could go next slide, please. So this is the NHS England Core 20+5 approach, which people may well be familiar with. There it is. You can find it easily on the internet. Just to say what these various elements are, as a reminder, Core 20, we've got the most 20% of the national population. Sorry, the most deprived 20% of the national population is our Core 20. The 5 are 5 clinical areas, and they're listed across the bottom: maternity, severe mental illness, chronic respiratory disease, a focus on early cancer diagnosis and case finding for hypertension. And the plus are populations at a local level that may not be captured in your Core 20, and they will be defined locally, people who with expertise in the area of who those people might be and who would benefit from a tailored approach towards health inequality. So this is being led by NHS England. I won't present on their behalf, but that's what we're taking into account when we're doing this work. Next slide, please. Thank you. So before my time, and thanks to our clinical fellows, so Sam Bartlett and Josie, for producing some of this work, who looked across our reports. So this was done a little while ago. And as you can see, these are our national reports over the last few years. Patient characteristics are often collected. They're often, but not always, reported. And they're often, let's say, sometimes, and not always, analysed. So work to do was the conclusion. And why might those reasons be? And that's what we explored in our workshops. Next slide, please. So these are the themes that we drew out of the workshops and our findings. We divided them into 7 for ease of talking through them. First thing to say is, as you just seen, there's plenty of opportunity for impact here. We can do some work and we can make a big difference. And we heard evidence from that in our workshops. And I'll just give you a couple of examples. We heard that a lower proportion of people on insulin pumps, so the preferred standard of treatment, are people of Black and Asian ethnicity. We heard that the more deprived you are, the more unlikely you are to have that insulin pump prescription, as I said, the preferred management. Hypertension prevalence, 3.4 percentage points higher in the most deprived quintile compared with the least deprived. The treatment to target for hypertension was lower in Black and mixed groups than in the Asian and white population, so differences of about 5 percentage points there. And prostate cancer, a different sort of inequality. We heard about age, not life expectancy, being more important in management conditions. So not necessarily frailty or health of the patient, but their age was a clear factor when it shouldn't necessarily be in management conditions. So plenty of opportunity for impact, as I said. So theme number 2, please, if I could go on to the next. Oh, sorry, I've kept them all on one slide. Yeah, I've got some notes here. Right. So theme 2, we found there was widespread support for this work across the programme. So it may be obvious, but good to say, we had support from all of our providers to have a focus on this. The pandemic's made it even more, come to the forefront even more, that people have been seeing these inequalities, and we're all recognising that. We had widespread support from NHS England. It was in the long-term plan commitments. It's in the operational planning guidance. There's the CAAW 20+5 approach. So lots of support for this work. So, green to go on this work. Theme 3, calling this a broad challenge, because we didn't find in our workshops that there were going to be any easy solutions to this. We all recognise it's going to be quite difficult and take quite a long time, and it's going to need lots of partners to do work on this. So we recognise we can't do it all immediately, but we can try to make system-wide. It's going to take system-wide developments, and we can try and play our part in that. So it's going to be a broad challenge, and we recognise that. Theme 4 was the challenge of missing data. So we were presented with evidence from our programmes, our commission programmes, that there's quite a lot of missing data. So it's sometimes quite hard to reach the conclusions, especially if the missing data is the population you'd really like to find out more about. For example, in hypertension, we heard that ethnicity data is missing for 21% of patients. So the biggest group, in fact, of patients missing data. There are real variation in rates of missing data between different programmes, different conditions, between different populations. We heard from paediatric diabetes about the amount of work involved in chasing missing data, and they've done a huge amount of work of phoning each hospital and asking about each patient and trying to get that data. But that's a huge amount of work, and probably not sustainable for huge audit projects. And we gave a little bit of thought to opt-outs in the future and what that will do. And also thinking about the way that patients are repeatedly asked for sensitive information. Why is it missing, and why are we asking patients so many times in different settings the same question? What are those barriers to willingness to self-report ethnicity? Is it linked to uncertainty about immigration status? Are we relying on clinicians to make those ethnicity judgments on behalf of patients? What are the problems? So we really need to delve into that a little bit more and be supportive of that. So our theme 5, we called it low quality of data. So talked about the missing data, but also the data we've got is not always of the highest quality. We have inconsistent data on the same patients. We have a poor recording of ethnicity captured in different ways by different projects in different groupings together. It's unclear to us sometimes. It was unclear to the analysts whether the characteristics are reported by the patient or by the clinician, or how they came about. And we recognise that clinicians may not always be able to or comfortable to make those decisions, especially in a firefighting, very busy situation, and they may not be able to use that information in a very good way. And we saw a lot of grouping together of either ethnicity, and we recognise the grouping together of deprivation data, and grouping together can really hide useful intelligence. So theme 6, our difficulties with our routine data. So obviously across the programme, we've talked about moving towards that use of routine data, trying to reduce the burden of collecting bespoke data specifically for the national audits. However, we heard that isn't always a straightforward switch, and there are a few difficulties which we would like to work on. We'd like our partners to focus on. The cost of obtaining that data, the length of time it takes to receive that data. I'm talking about HES data, routine data like that. The cost of analysts to analyse that data, and the difficulty of finding people with the right skills at the right level to analyse that data and use that data in an effective way. And the frequency that data is available and how useful it is, and the challenge of working across devolved nations with different and devolved trusts with different ways of reporting and all the different data that comes in. So we found inconsistencies there. Theme 7, final theme. This is about the use of outputs by healthcare services. So how well can our healthcare services actually use the data and the reporting that comes back to them, how difficult is it to interpret, and the level of detail, is it useful, is it the right level of detail, how useful is it to make local changes, and that's something we're keen to focus on, to focus with the programs on their outputs and how useful they are locally. And especially if healthcare services told us if they're unsure of how reliable that data is, how valid it is. We know we're working sometimes with very old census data, and is the coding and is the accuracy really what it could be in it, and that makes people nervous to use it. But we want to give better reporting, obviously, so that people are empowered to make that change. So where do we get to with all this? We brought together our themes, and that's really the start of this work rather than the end. Could I have the next slide, please? So we gave ourselves some next steps. And number one, picking up on what I've just been talking about, to support our healthcare providers around the country to make use of that data, to look at how useful it is, the reporting, our outputs that we produce across the programme. To encourage healthcare providers to engage with particular populations, so any support we can give for that, recognise there may be different needs in different areas, in different regions. To look at our projects' quality improvement plans, they all now have a quality improvement plan to support them with that and their outputs and their recommendations, and to make sure that health inequalities becomes a focus of those plans in the future. We are looking at determining a minimum data set of patient characteristics that should be reported, noting what I said about how difficult it is sometimes with missing data, with the quality of data, but that's somewhere we could get to. Encouraging and working with our providers to make sure that all data captured is in fact then reported, so that trust services get it back. A better standardised reporting of key characteristics across the programme, something that we would like to work towards, and then to move beyond that data into a more helpful qualitative coding of information that providers, that services can use in a helpful way. And then next slide, please. What can other bodies do? So these are our challenges to some other bodies that we'll be working and picking up with them. Ensuring alignment to that CAAW20+5, if we have that as our national initiative, how can we all align to it? Pushing, and I know it's coming, to update the 2001 census categories with the most recent census. Apparently it's coming, but it's not there yet. So 2001 is obviously some time ago. And this is in terms of if you're using census data to compare your population with what you think's out there in the wider population, you know, it's pretty outdated now. And for seeing how many, you know, checking your case ascertainment or things like that. Supporting our frontline workers on a better quality of recording of ethnicity, as we identified that as a particular problem, and how we can better help people to do that. Facilitating use of patient level data set across services. So what I was saying about the same patient can have different characteristics recorded in different places at different times, and maybe we could help people. Possibly with number 5, with using the app, noting that that's for the digitally included, but there is some work we could do around that. Number 6, having a better public understanding about why data is collected and why it's of value. I mean, not just with patients, but also with healthcare professionals, with sites, with, you know, make sure that story is told and how audit data actually contributes to better care in the future. And linked to that, trying for us to understand the reasons why people might be reluctant to share their data and to support them in doing so. And I think that's my final slide. Sorry, I don't have that. Is that my final slide? Yes, it is. Great. So thank you very much. Very happy to take any questions and to share our work, and more to come from us on this project.
If it's okay, Caroline, just as you catch your breath for a second, I think we'll take questions at the end, and you're getting some thanks, huge thank yous, lots and lots to think about, lots of dynamics. There's the principles of, you know, if an individual doesn't want to share their information, the importance of that, but how it does affect, but also thinking about the importance of information, getting information out to our patients and communities, so they're aware of what the information is used for as well. So, are we ready, Caroline?
I am. So thank you. I mean, what a pleasure. So we are going to be presenting the winners of the Health Inequalities Audit Hero Award. And as Sarah hinted, the word on the slide is winners, because we have 2 in this for today. One national winner, one local winner, let's call it that. And the reason for that is because we just couldn't compare them easily, and they were both brilliant projects. So in the end, 2 prizes awarded.
Caroline, can I just double check? Do you want to announce both winners first of all, or we invite the first winner, we announce and present, and then go to the second? How would you like to do that?
I have in mind to announce both, and then both are going to speak one after another.
Lovely.
So I'm going to announce the local winner first. Is the Maternity Cultural Transformation Team at Epsom and St Helier NHS Trust. So well done for your brilliant work. The
Congratulations.
The judges agreed it was a fantastic project, had clear evidence of sustained improvement, and you'll hear more on the projects in a minute.
The team are here ready. I can see them smiling.
Oh, there's lots of clapping. Thank you. That's nice to see. And this is talking about quality improvement methodology to identify areas of inequality in their maternity population and improving access, looking at removing the language barrier, increasing information provision. Anyway, I won't give their talk for them, but very impressed. And then a national winner is the National Paediatric Diabetes Audit. So well done to them. So that's their national project. Again, the judges described the audit as an excellent project and doing really vital work to improve health inequalities within diabetes care of children and young people. So such an important group. And I mentioned them earlier, actually, I gave them a heads up because we heard how they are making sure that they are collecting data on every single patient, and that's going above and beyond, and they are really trying. So we're going to hear from the national winners first, I believe.
We are indeed. Holly, welcome. Would you like me to just press the buttons for the next slides, or would you like to take control?
Is it right if I attempt to take control, because I think there might be a couple of animations.
Okay. Yeah, of course.
If I mess it up, I'd be delighted for you to take it back off me.
Yeah, I can't see a button that says you can take control, actually. Let's see.
I'm going to have a go. Okay.
What's the worst that could happen?
Yeah, first of all, just thank you so much for the award, which I'm absolutely delighted to accept. Not really just on behalf of our team, but the paediatric diabetes community, because it really is their efforts to collect that data, to submit it, and to do things with the data that we report that means that we have seen the progress that we've evidenced so far. So yeah, thanks a lot. It's very, very motivating as well as rewarding to have that work recognised. So thank you. Right, I'm taking control now.
Thank you. All I'd ask is when you come to your last slide, if you can leave it on the last slide for us,
Leave it
please.
on the last one.
Yeah,
Okay,
and I'll take back control.
Okay, well, I've pressed the button, but nothing is happening. So would you
just say next slide.
Slides up?
Not a problem.
Next slide, yeah. Okay, I can't see any slides right now. Can anyone else?
Yeah, we can.
You can see slides. What have I done? What have I done then? Okay, if I take it off gallery mode, I could see your slides, Caroline. Why can I not see? Man, this is a terrible start. Okay, do you know what? I've got the slideshow minimized on my screen, so I'll talk to the slides that I can see on my screen.
Okay.
We've got starting with background to the audit, if that's
brilliant.
Yeah.
Okay, good. I'll speak to that slide. So I'll start by saying a little bit about our audit. So we collect data submitted prospectively throughout the audit year by paediatric diabetes units in England and Wales. So if you are a child or young person with any kind of diabetes in England and UK, you will be getting your care from a PDU rather than your GP. And we measure performance against standards of care and outcomes that are recommended by NICE for every single child from every single appointment. So it's a very rich data set, many, many rows of data per patient. The ethnic categories we use match those within the NHS data dictionary, which we aggregate, and then we link postcode data to LSOA data, and then link that to deprivation quintile data to inform our analysis. So next slide, please. There are some animations here and I can't see what you were showing, but
so if I just talk you through, Holly, I'll just put everything up on the slide. So you've got your two arrows and the two tables.
Yes, excellent. So Just to give you an idea of where we were at just over 10 years ago, we had 25% with uncategorized ethnicity in those days, and that really limited the conclusions that we could draw about the care and outcomes received by different ethnic groups. So we've done a lot in recent years to get to grips with that. So today we have less than 5% with uncategorized ethnicity in our most recently published audit, which is fantastic. Very few with not known ethnicity, some with not stated ethnicity, which is when the patient or family has made a conscious decision not to state their ethnicity, which is fine and less worrying for us as an audit. Deprivation data is missing for less than 1% of all patients, so we can be confident that we're starting with a complete and robust demographic data set to then interrogate. Next slide, please. So thank you so much. So how did we achieve this? The data capture system flags every patient's record as incomplete every time there is their demographic data is entered with missing data. And we look at the ethnicity and postcode data as part of the validation process. So we're doing that right now. We've got our annual data set, we've extracted it from the data capture system, and we're now going through all of the PDUs, the pediatric diabetes units, to check the completeness of their ethnicity data and their postcode data and their age data. So if there are any significant omissions, we can go back to that unit and ask them to re-upload. It does add time to the process of analysing and reporting the data. So, you know, that there is a cost as well as a benefit, but we think it's really important. And by this stage in the audit, because the audit is mature, because we've been doing this for a while, and because there is general agreement within the pediatric diabetes community that this data is important, they're well trained by now. There's not much follow-up that we have to do. And by reporting our outcomes broken down by ethnic category and deprivation quintile, and performing case mix adjustment using this information, we've supported PDUs to understand that it is fundamentally important to the audit, which is fantastic. So next slide, please. Okay, there are a couple of animations on this one, I think. There are just a couple of graphs on the one slide. So why is it important that we collect these data? And obviously, we all probably understand by this point in the presentation or the lunch and learn session, that it's only by highlighting inequalities we can then motivate and inform QI strategies aimed at closing the gaps identified. So here we have a graph. I think the one that you can see is figure 66 of our most recent report, which is a percentage of children and young people with type 1 diabetes using a real-time continuous glucose monitor by ethnic group and deprivation quintile between the last two years. Yeah.
Holly, sorry to interrupt, but it's actually not appearing on the screen.
Okay, that's
what
fine.
I'm seeing on the screen is slightly different. So if you just talk your way through it.
That's okay. I think you've probably, the one behind that is the HbA1c trajectory, I think. Is that right? Is that a nice line graph?
Yes.
Excellent. All right, I'll speak to that one.
Okay.
So this graph that you can see charts the HbA1c outcomes, the mean HbA1c for each ethnic category from 2003 up until the present day. So many of you will not know what HbA1c is. You're lucky if you don't. But in diabetes audits, we're extremely lucky because we've got this lovely biological measure of the outcome of care. So HbA1c, it's a blood measurement which gives you an average indication of glucose levels in the body over the previous 3 months. So in type 1 diabetes, it's a constant battle to match your insulin with the carbs that you intake, taking into account exercise, taking into account even the temperature, whether you're ill or not. You're always battling to keep your glucose in the recommended range. If you've got a high HbA1c, it means that your glucose levels have been quite high over time, and that can lead to complications because when your blood has got a lot of glucose in it, it's stickier. these are very lay terms, obviously, but basically you're going to have more complications if you have high glucose levels for a long time, because that sticky blood will clog up your smaller blood vessels, which are very important for your organs and peripheral and your toes, for example. So that's why you get complications with blindness, amputations, if you have high blood glucose levels for a long time. Anything over 80 is considered very high. So you can see in this graph 10 years ago, the mean HbA1c for a lot of children was in that danger zone. So over the last 10 years, I'm delighted to show you that for all children and young people, we've seen meaningful clinically significant reductions in HbA1c. But what you can also see in that chart is that inequalities persist. So you can see right at the top of that chart, the grey line, that is the mean HbA1c for Black children and young people with diabetes, and it's consistently higher than every other ethnic group, even though you can see an improvement. And so I think if you click again, you should see the real-time glucose monitor graph. Can you see that yet?
It's happened the other way round for some reason on this animation. So we've now got the graph with the figure 66.
Yeah, great, excellent.
That's okay, brilliant.
That's absolutely
okay,
fine. I'll
and
briefly
just
talk about. Oh,
gentle sort of reminder of if you can finish up, please, at past, if that's
yep,
okay.
I will. Yes,
thank
no
you. I'm so sorry.
No, it's fine. So yes, this is just another example of inequalities that we found within the MPDA, looking at who is using a real-time continuous glucose monitor. So as I said, it's a continuous battle if you've got diabetes to balance out your blood glucose in the context of everything else that's going on with your life. And historically, the best way to monitor your glucose has been to do finger prick tests. But there's a newer technology called a continuous glucose monitor, which sits inside your skin, just on your skin, and sends continuous readings about your blood glucose, which you can then use to inform your diabetes management. And you can also discuss the output from this device with your diabetes team and look for trends and patterns and see how you can improve your self-management of your diabetes at home. So our data has shown that children and young people using these devices typically have much better outcomes than those who are not. And so you can see in this graph that there are inequalities by ethnicity and by deprivation quintile. So you're more likely to be using one of these devices, which can improve your future health and your diabetes management, if you are living in the least deprived areas and if you are of white or mixed ethnicity. You can also see that there is improvement year on year. So we've got the 2021 data in blue there and the previous year in orange. So again, there's increases across the board. And the biggest percentage increase actually was amongst Black children and young people, which is fantastic because this graph, you might have seen a previous iteration of it. This graph goes around Twitter all the time as a stark reminder of the inequalities in care, and teams have really taken that and tried to encourage families to access these technologies in demographics where typically they haven't so far. And I think we've still got work to do to understand why, where these technologies are more available, why are some families choosing not to access them, or why are they not being offered them? So we've got some engagement work planned around that. And there are some large scale national research studies planned as well. It's not just as a case of handing out these technologies. They need a lot of support for correct use. So it's a complex issue, but our data really highlights that there is an issue. And if I could move on to the next slide, please.
There we are. Yep.
Yeah, it's really important that we collect these data and use these data as much as possible. I think we can get a bit frustrated sometimes. That there was that government report last year that came out saying there's no structural racism, there's no systemic racism, and people like to think, oh, it's just deprivation, as if just deprivation is something that we can just shrug our shoulders about anyway. So what we like to do is look at the relative impact of deprivation and ethnic category, so we can tease out, is this a deprivation thing, or is this actually an ethnicity thing, or is it a bit of both? And so our regression modelling, for example, has shown that even when you correct for deprivation, there are still ethnic differences in HbA1c attainment and with consequences for health in later life. So it just really does help us make the case that we need a culturally competent approach to resolving some of these inequalities. Next slide, please. So
Right.
what?
Just coming up, you've
2
got some
minutes,
animation. Yeah.
Oh, have I? Oh, okay. So what impact has our reporting had? So we do case mix adjustments to our HbA1c. The clinics, they all want to know, we report many metrics, but the one they want to see is that clinic their average HbA1c, because that is a measure of how well their children and young people are self-managing at home. And some clinics seem to be better at supporting these families to self-manage than others. So we case mix those figures as well as producing the raw results, because clinics in very deprived areas, often inner city areas, before we did this, they could say, well, our results aren't great because we're in a deprived area. And so when we case mix adjust, they can't explain away inequity between services based on their local population. It provides justification for expenditure on engagement and research activities, examining the barriers to achieving excellent outcomes amongst groups not currently doing so. As I said, that use of diabetes technology is shown to improve outcomes, that there's more to tease out in that than simply blaming teams for not handing these technologies out equitably. There's more going on. The impact, as I explained, that the biggest percentage increase in use of real-time continuous glucose monitoring was amongst Black children and young people on our most recent report, and that's really good to see that the gap is closing. And focus on inequalities in diabetes tech use have supported efforts to ensure that technology that I've been describing, continuous blood glucose monitors, that they're available to all children and young people now via the NHS with nice guidance to back that up. That's happened this year. So it's been a very worthwhile endeavour, and it's something that we're obviously keen to carry on until those gaps are closed. Thanks for listening.
Thank you so much, Holly. Really, really interesting presentation. I'm well done with dealing with the technology. I think we got there, apart from there was just one slide that was a little bit off kilter, but you can see the congratulations coming through. We're going to take questions after the next presentation. Okay, is that all right?
Of course.
Caroline, are you okay if I head across to the next presentation?
Oh, yes, please do.
Okay. Michelle, are you ready?
I am ready.
Welcome, welcome.
Hi.
Here we go. Over to you.
Hello, my name is Michelle Knight. I'm consultant midwife at Epsom St Helier Hospital, and I do have my colleague Miss Johnson, our obstetric consultant, by my side. I just wanted to thank the previous speaker actually to a really interesting audit, and I'm delighted to also we are delighted to be a winner of this award as well. And oh my goodness, you know, to be up against the previous audit, we're very humbled. So thank you very much. I just want to give a little bit background to the our team. So our team is the Maternity Cultural Transformation team, and we came together to focus on addressing inequalities within maternity services for our women of Black, ethnic, minority and Asian groups. It was important that we had a strategy for looking at current service provision, looking at the gaps in our service, and where as a team we could actually start to addressing inequalities. The focus has been very much around language barriers, interpreting services, and also improving clinical care. And today we'd like to present to you our clinical audit on our vitamin D for women from this group of women and cohort of women. And I'm going to hand over to Miss Johnson.
Hello, everyone. So as Michelle said, we focused on a few things that we want to present today. And if I could just ask for the next slide, please.
Yes, of course.
Thank you.
Now, bear with me just 1 second. Someone else has taken control. Bear with me just 1 second. Could I ask whoever is trying to take control of the slides, please, if you can just bear with while I reload. Michelle, just bear with me 1 second. I'm so sorry.
That's okay, no problem. So the next slide is actually our team, just to put some faces to names, really.
Lovely, and we will show that picture. It's an amazing picture. I absolutely love that one. Right, should just start loading for you in a second. And then give me just 1 second. I'll need to go to the right slide for you.
That's it. It's come up, Sarah.
Are you able to hear us okay?
Perfect. Thank you.
Yeah. So again, if I can please ask people to not try and take control, please, if they can just leave it with me. Thank you. Okay, there we go.
So that's our team.
Our team. So we do have other members of the team who are also who have joined the call as well. So we've got Diane Ware, Patience, Ohikena, Louise Emmett, and they're all on the call as well. So the next slide, please. So we had a number of things, as Michelle has mentioned, that we've been working on, but we are presenting to you today an audit that we've conducted with regards to increasing vitamin D uptake among our pregnant women. So the background to this is that during the COVID pandemic, it became apparent that vitamin D deficient individuals were having more severe forms of COVID infections when they got infected. And we recognize that the recommendation in pregnancy is for 400 units of vitamin D, and that would be found in every routine supplement, and patients who are on a Sure Start vitamin supplement would also have 400. We had to conduct a bit of research to understand what is the risk for our pregnant women, and we then realized that patients who were non-Caucasian, so if you had black skin, you're more likely to be vitamin D deficient. And if you read through the evidence, the recommendation is that patients who are who have non-white skin are recommended to have a higher dose of vitamin D, and that's 1,000 units. This would equate to, you could ask patients who are on a Health Start vitamin, they can double the dose, or patients could actually get a 1,000 units separately, and it could be got from any grocery store. So we undertook this project to see if we can improve the uptake of vitamin D among our pregnant women who had non-white skin, because we knew there was more prevalence of deficiencies among such patients, and use the opportunity to also educate our staff about vitamin D use in pregnancy. And that was because a lot of staff were being asked by their patients as to, can we take extra vitamin D? Should we check our levels? So there was so much, going on, and staff were unaware as to what the correct guidance was. So it was good for us to have the facts and give our staff the information. Next slide, please. In addition, we also looked at the NICE guidance. So there is a public health guidance number 56, which talks about vitamin D supplementation in specific population groups. And a number of standards we felt that we could use in our audit to measure ourselves against. And these included, activities to increase awareness about vitamin D, as we just said, ensuring that health professionals could recommend the supplements to pregnant women, particularly when they come for their first booking visit. The third standard there, standard 9, was raising awareness among health practitioners of the importance of vitamin D. And this include groups at risk of low vitamin D status, as I've said before, patients with non-white skin, and also looking at local policies. Standard 10 talks about raising awareness of the importance of vitamin D supplements among local populations. So that's about education of our women. And 11 talks about monitoring and evaluating the provision of uptake of vitamin D. Next slide, please. I'll hand over to Michelle for this.
So apologies, the graphics looks a little bit out of kilter on here, but basically our methodology was that we had a timeline, and it was important to obviously follow steps when we're conducting the research, but also looking at the evidence and how we were going to implement this within our trust for our women. So in January 2021, we advertised the use of 400 international units vitamin D to ethnic minority group women by use of a poster, linking into some of the focus group work as well that we do within the work that we do as a team. In March 2021, the co-production with women, and again we're very focused about sitting with women and co-producing our guidance with them, with the needs that they want. What is it that they need and what do they want, and that we can actually communicate effectively with them and sort of allude to the fact that actually some of these things are really important for them, especially within pregnancy. We engaged with the biochemistry team within the trust. There was no routine vitamin D testing in pregnancy at all, so therefore that then generated a recommendation of 1,000 international units. In April 2021, the biochemistry and the multicultural transformation team agreed that 100 international units is the dose that we were going to use. And then we started to update our electronic records within the trust to ensure that staff were aware that vitamin D is recommended for these group of women, and that it's very clear in the management plan when booking women and when doing clinical care as an alert, to sort of alert the staff so that in terms that they know what needs to be offered and to ensure that it's actually done. In June 2021, there was a development of the vitamin D guidance, and a lot of what the work that we do is looking at our current guidance within our clinical care and updating that in terms of addressing inequalities, and we included this within our vitamin D guidance, and we disseminated it across the maternity team. In April 2022, the re-audit of consecutive women who birthed at St Helier to examine the adherence to the guideline. Has this worked? You know, what is the uptake of the current vitamin D, and has it improved at all? Next slide, please. So the audit outcomes was that 85 women delivered between the 1st and 18th of March in 2022. Pregnant women of an ethnic minority origin formed for 53% of the women who had delivered. 62% of these women had non-white skin, and 89% of the women with non-white skin were advised to commence 1,000 international units of vitamin D. 16% of the ethnic minority women required an interpreter, and in all, our interpreting services were employed to actually communicate this information. Next slide, please.
So that's just a graphic description of what Michelle has just presented to you. So we had a total of 85 women who delivered, of which patients who were of Black and minority ethnic groups, as you could see there, were 45 in total. And we had of those with non-white skin actually formed, I think it was 25 of them. Patients who had vitamin D, sorry, 28 of them. Patients who were given vitamin D appropriately were 25 out of that 28. They had 1,000 units. There was one patient who had been advised 400 units. And with two patients, there was nothing recorded about vitamin D advice. And when we set up this audit, we were hoping to achieve at least 70%, of patients who should have been appropriately advised. So it was really good to see that 89% of the patients actually got the right advice. We had a number of women who required interpreting services. In total, there were actually seven patients who required an interpreter. Next slide, please. In addition to the vitamin D outcomes, we also found out that there are other things that we achieved by embarking on this project. So firstly, there was staff education. We were educated just by doing our literature search, because initially we were thinking of rolling out vitamin D testing to all pregnant women, because we have such a high percentage population of patients of Black, Asian and minority ethnic groups. We have a good number of obese patients where we know there's vitamin D deficiency as well, and patients with chronic health conditions. So at one point we were toying with that idea. However, on doing our research, we recognized that routine testing of vitamin D is not recommended except if a patient is in the high risk category. So those with chronic health conditions, osteomalacia, and that sort of thing. So therefore, we rolled out the vitamin D use. So staff were educated, we had tutorials, we sent out risk newsletters as well, put alerts on emails so that staff were aware of what the guidance was. There was good multidisciplinary team engagement. As you can see there, we've mentioned close working with the biochemist, just to work out what would it cost if we're doing vitamin D levels, what's your advice. We spoke with our specialist midwifery teams, tried to work with them so they could give the advice to their own midwifery teammates when women ask these questions. Should I be tested? Should I take extra vitamin D? What's the recommended dose? So we're able to answer all those questions that were coming at us initially. In addition, we spoke with our obstetrician colleagues, and that's because for some patients who are actually high risk, it's important that obstetricians are aware that they could do a vitamin D test and act on those results. We developed guidelines. So there was a guideline developed for vitamin D, which was put in a very simple flow chart, very easy for staff to understand. And when we started our tutorials with the midwives, specialist midwives, they actually were so happy to have that flow chart. It was one of the best things I think we've done. Yeah. Really good feedback.
Yeah, definitely.
It's good that we were able to use this innovative method for risk reduction because we actually engaged with our IT midwives in order to put a prompt onto our electronic records, what we call Badgernet. And on this records, staff, when they're booking a woman from a Black, Asian, minority ethnic group, the prompt would come up asking the midwife to discuss vitamin D 1000 use. And once she has selected that box, the information would then be downloaded onto the patient's records and it stays there for the duration of her pregnancy. So in this way, it prompts the woman as well as staff, and she always has that information to hand. So patients would became more aware of what is expected, and it was useful to have this information in the records when we were now auditing the notes. So it had this, double whammy effect in the sense that we could use it as an audit tool also. There was good patient engagement because we realized that staff were utilizing the interpreting service, which is one of our other goals that we've been trying to achieve since we formed the group. And it was really good to see that out of the 7 women who required an interpreter, all of them actually had an interpreter during their clinic episodes. Can we have the next slide, please?
Thank you.
Thank you. So, of course, the study has had its own limitations in the sense it's like I said earlier, we went, measuring vitamin D levels, and certainly we rely on staff asking about patient compliance. So that is something that would need to be followed up. But we do recommend as part of our recommendations, we therefore are advising staff to kindly continue those conversations with women, check up on whether they are following the advice and taking a higher dose of vitamin D. And in addition, because this model has worked, it's good to roll this out, to our division, because we could use a similar model for other risk issues. For instance, patients with who are obesity, other things that we want to promote. There's so much more that we can do just using the same risk model. And we're pleased to say that we actually did present it. So we've actually, fulfilled this recommendation because we presented just on Thursday last week on our quality meeting, just so that the trust is aware of this model. Thank you. I think that's our last slide.
I think it is.
Thank you.
I did send the poster as a separate presentation for you to have a look at that we presented last Thursday.
Thank you so much, Michelle, Antoinette, and to Holly. And you can see congratulations coming in. Just because of time, we're just going to go straight to networking. I'm going to take down the slides and hand over to Sarah, but two great projects, two very different projects, but each looking at health inequalities and reducing those health inequalities. So thank you, absolute thank yous. It's a pleasure. Sarah, over to you. And if we could wrap up just a couple of minutes before 2 o'clock, please, just so that I can do some closing comments. And Becca, can you please put our evaluation form in the chat now? So as folk are thinking of their questions, they can be completing. Over to you, Sarah.
Yes, and thanks again. Two fantastic presentations and talks from Caroline and yourself, Sarah. I really thank you for that. So we have Diane Rear has her hand up. Diane, would you like to ask a question?
Oh, actually, sorry, that was a mistake. Just want to say congratulations to my team for their presentation.
Oh, right. Okay. Okay. Anybody else with any questions? I mean, I'd be interested to hear from other people who work with Michelle. I know there are other people on the call. What were your highlights or your main takeaways from on a personal level from being involved in this project?
Hi, it's Diane speaking.
Hi, Diane.
Hi, I just think it was, for me, this is probably the sort of first time I've been involved in this kind of audit. So actually just really getting the engagement of my colleagues and the women was important. And I think in terms of sort of the work we're doing generally in our group, looking at, health disparities, this was something that was such a thing that we could easily get right, if we get it right, the benefits for women will be so great. So it really was, from my personal point of view, a really interesting audit to be involved in, and just seeing the outcome and how we've made a change within our organisation is absolutely great.
If I can add to what Diane is saying, this is Patience, the awakener. I would say that at the beginning of the audit, we knew exactly what we were going to do, but however, we didn't know that it's going to involve a lot of kind of research that we just thought, we just do their routine anti-D and vitamin D test, and that would be it. And then we just give them according to individual women. We just kind of advise them how much to take. Then we realized that it's not as straightforward. We're not ahead doing research, looking at papers, people that have actually done it before. Then contacted the lab, and that was when they now said there is no point testing them because it's actually a waste of money. That there is really. Then we talked about the toxicity. So we delve into a lot of things because we know that the benefit outweighs all the work that we're doing, and at the same time we're all very kind of enthusiastic as to, if we can get this right, then we can actually use this as a base to a lot of other audits that we're going to be doing in the unit. So it was a very well, I would say, yeah, it was hard work, but I think it didn't really seem hard work to us because we know that we're providing our women with the best care possible in line with the evidence that has actually shown, particularly with COVID, because we want to keep our women on that optimum health. So that is what I took away from there.
Thank you very much. Thanks for sharing that. We have a question in the chat. Just bear with me for a moment while I just scroll up. There was a question to both speakers. What challenges, if any, have you had to face during the pandemic with limited face-to-face patient contacts, and how did you overcome them? Holly, would you like to take that first?
Yeah. So as an audit team, I suppose there were different challenges for us. I suppose, like everyone who was suddenly working from home, we had personal challenges organising that. But in terms of actually collecting data during the pandemic, we were really very lucky. We said to units, just record what you can. Face-to-face care might not be happening, but on the rare occasions that it does within we're lucky because we're looking at a complete year of care, and there wasn't a complete breakdown in face-to-face care for the entire year. So we just reassured services who might have been nervous about submitting data that was less complete than in previous years and were worried that they would be penalised on that. We just said, look, just let us know what went on in your service. Okay. Just record whatever you did do, record it, submit it to us. And then we just said, we're probably not going to do outlier reporting. We need this data to record the impact of the pandemic on patient care, so we can learn and adapt in previous years. So we got a brilliant response, and I think I know that for the 2020-21 audit year, we got 100% of services submitting what data that they did have.
That's great. Fantastic. Michelle, you wanted to come in?
So yeah, so for our service, it's quite difficult for us because obviously our service will run concurrently throughout the pandemic. You know, nothing would change from our service provision perspective. But of course, we was in a situation where the women didn't want to come into the hospital. So a lot of our counselling service went online. They didn't want to come into the hospital. So there's a lot of unpicking of that and reassurance with the women. Of course, they were an unvaccinated population in the early days of COVID. So our year last year, 2021, was very challenging because obviously we then have women who are unvaccinated, didn't want to be vaccinated. So that completely changed, changed it on its head a little bit, especially around this group of women who were very scared about having vaccinations. So a lot of work went in terms of reassurance and meeting these women face to face ideally, but of course lots of telephone conversations and increasing their access and keeping in touch. Keeping in touch with these women was absolutely key for our service. So for us, we were very responsive to the needs of the women, I feel, because we had to be, and we were very conscious that, these groups of women are already in a sort of less inequality perspective. So it was even more important to work a bit harder in that area, which we did, and the outcomes. And like I say, going back to originally what you said earlier, for me, in terms of what I've learned from this is that how something like this, which appears to be quite simple, had such a massive impact.
Yeah. It sounds it. So thank you so much for that. Anybody else got any questions that they'd like to ask, or any comments that they'd like to make in relation to what we've heard or challenges that they're facing?
Can I just pick up really quickly in the chat at 12:34? There was a piece from Tanya Stacey. Tanya, are you still with us? Because your question, I think, is really important. Are you there, Tanya? She might have had to drop off. Here she is.
Oh, there she
I
is.
am here.
Tanya, would you like to answer your question?
Well, yeah, with Holly's presentation, she touched on QI. So I work in Gloucestershire Health and Care in the QI hub. So me and a colleague, we've got a meeting next week actually to look at how do we weave health inequalities within our kind of methodology of QI. But I've just been messaging her actually because it kind of highlighted about we need obviously that wider discussion with our clinical audit colleagues as well about how do we look at that as a system rather than, I guess we need both. We need it to make sure that we're using QI as an opportunity to reduce health inequalities, but also looking at data and trying to stratify that data to see, are we actually causing wider gaps or creating gaps when we're doing improvement work? There's a really interesting case study where they were looking at breast examination and they had their improvement aim and they actually got their improvement aim, but when they actually stratified the data during that quality improvement project, Black women were actually decreased in number of breast examinations. So actually the project made a gap. So yeah, I'm really interested in that.
Unintended consequences, isn't it? Sarah, can I also say at 12:34 there's a question from Bonnie Wiles as well, and I'll let you carry on, but if Bonnie can speak as well, if she's still here, that would be amazing. And thank you Tanya, that was great, and it looks like you've got plans moving forward. Do you want me to read out Bonnie?
Bonnie, are you here?
I am here. I am just going back to find what my question was because I can't remember it off the top of my head.
Yeah.
Have you found it, Sarah, or if not?
I'm still searching.
We're mindful of time. We will get.
Sorry, go on, Sarah. Do you want to go ahead if you've got it there?
I'm literally going to. There's so much in the chat. This is such a wealth of information.
It is.
So
yes,
Bonnie, what you were talking about was looking forward to hearing from a local perspective what would be the most useful in terms of health inequalities data being reported from national audits. So I think there'll be a lot of people that will be really interested to hear about that. Perhaps Holly, you could give your thoughts on?
I'm sorry, I missed the start of that question.
Looking forward to hearing from a local perspective what would be the most useful in terms of health inequalities data being reported from national audits. Let's ask the question, because I think it's so important when we look at so much data being collected.
Absolutely, yeah. No, we're very keen to ensure, and we have to ensure to maintain our 100% participation in the audit, that the feedback that units get from the data that they submit enables them to inform improvements in their service year on year. So every paediatric diabetes unit participating in our audit gets a 20-page report breaking down all of their results in as much detail as possible, so they can benchmark their year-on-year progress against themselves, against others, and that, you know, they challenge us on what they'd like to see in those reports. So for a few years, we were asked to provide a breakdown at unit level on tech use, diabetes tech use between different ethnic groups, because PDUs, staff teams, it was an issue that they're aware of, that they wanted to do something about, and they wanted to benchmark. They wanted to see where they were compared to others. And for a few years we said, oh, we can't, small numbers, we can't put that in the public domain. But then the use of tech got there was increased use, and we were able to do it for about half of services, so that was better than no services. So I think just really tailoring our reporting to the priorities of local teams and empowering them to use that data to see whether or not their QI projects are having an impact year on year or more frequently throughout the audit year is key. Otherwise there's really no point, is there?
Thank you, Holly. I'm really mindful of time. We've just clicked to 2 o'clock. If folk can give us just 1 minute, I will round up. This is the start of a conversation, a really important conversation. Clinical audit is central as a tool that we can use to help reduce health inequalities. It's how we take it back to our organisations. Huge thank yous to Michelle, to Antoinette, to Holly. Fantastic projects. We're going to get some case studies up with regards to your projects that will be available shortly. Thank you to everyone. Take the challenge. Let's look at how we can actually take forward some prioritised health inequality clinical audits. Thank you so much, everyone, for your time. To Caroline, to Sarah, to Vicky, thank you. Tomorrow we have Future Proofing Healthcare. Please do join us with Mojan, who is our South East Regional Network Chair, and James Mountford from NHS England, talking about that vision of future proofing healthcare. Clinical audit is central to that, of course. Please do fill in our evaluation, give us feedback, and thank you. Have a fabulous rest of your afternoon, and get tweeting. Tweet at NQICAN. Let us know your thoughts, and look forward to seeing you soon. Thanks ever so much, everyone. Bye-bye.